Well, thank you, and it's really great to see this audience. I hope this provides you with a different bent on some of the challenges with doing research in hepatology. I'm a pediatric hepatologist in Colorado, and my research is exclusive in large cohorts of children with various types of rare liver diseases. Many of the concepts that we've heard already today pertain to doing research in children, but as you'll see in a second, there's some specific areas where we have to consider other aspects. Here is my disclosures. So what my goals will be for the next 20 minutes or so is to discuss some of the challenges that face pediatric hepatology research, to emphasize certain developmental characteristics of children that influence how you design your clinical study, and particularly clinical trials, talk about physiologic factors in children that are different than adults, talk about pitfalls, and then a few ethical challenges that are specific to pediatrics. So first of all, why is it necessary to perform research, and particularly clinical trials in children? Well, disease processes in children are clearly different than in adults, and some of the diseases, such as biliary atresia, for instance, don't even occur in adults or even in older children. So we can't take results from adults with primary biliary cholangitis and apply those to a 1-month-old with biliary atresia, for instance. Also, the physiologic makeup and particularly pharmacodynamic responses to drugs not only are different in children, but they change with age. Again, therapies that are used in adults may be inappropriate to use in a child. One doesn't even think about capsules or tablets in adults. You assume everybody can probably swallow those, but in children, we frequently have to make up suspensions. There's stability issues and other things that you'll see in a minute. And then finally, we need to focus on the diseases and the treatments that are specific for the children's needs when there's limited evidence of efficacy. How do we manage that in children? So just to give you an idea here, the burden of pediatric liver disease, roughly 1 in 2,500 live births results in a child with direct hyperbilirubinemia, or what we call cholestasis. Biliary atresia is perhaps the most common disease. It's still about 1 in 10,000, which makes it a rare disease. Cystic fibrosis liver disease is a bit more common. Alpha-1 antitrypsin deficiency in the right population is about 1 in 2,000, but only 20% of those patients develop cholestatic liver disease in infancy. 10 to 20% of children will have some variation of fatty liver disease, and autoimmune liver diseases are clearly on the rise in children as they are in adults. So, the most common childhood liver disease, NASH or NAFLD, right now, there's no treatment for it all that's FDA approved in the United States. We also have no FDA-approved treatment for pediatric cholestatic diseases and most genetic and metabolic diseases. So this really creates a dilemma on how to treat children with drugs that have never been tested in children, but might have some efficacy in adults. Most of the recent therapies of hepatitis C have yet to have clinical trials run in children. And because children are a relatively small market, that is children with liver disease, compared to adults in everything except NAFLD, there's a lot of challenges into getting clinical trials done, the expense, the design, finding enough children to enroll, et cetera. So it makes it, again, another barrier. Finally, children don't have a political voice, they don't vote, and are frequently neglected in many healthcare issues. This is just one of them. So pediatricians, which I am, have to be the voice of children and speak out and be politically active, whereas children themselves cannot. So in pediatrics, our goal, particularly for rare diseases, and again, almost all pediatric liver diseases, except for NAFLD or rare diseases, is to really find the right drug, to treat the right population, get the dose correct, the right formulation. We have to look at trial designs. Ray did a great job of using large databases for trial design and pediatric hepatology. That's a real challenge. And then finally, the correct endpoints for the clinical trial. So our goal is generally to find a sustainable infrastructure to perform clinical trials in children, to develop cooperative networks that can work together, consortia, because again, when you're dealing with rare diseases, no single center will see enough patients, to develop a workforce and train a workforce, and that's part of why we're here now, that's knowledgeable and understands how to conduct clinical trials, and then to be able to manipulate and use the regulatory system to develop processes that are efficient so one can get these done in a reasonable period of time, again, with the overall goal to find new therapies for childhood liver disease. And I just wanted to show you one example of a cooperative network. So about 15 years ago, National Institutes of Health realized that most childhood liver diseases were unable to be studied because, again, a center that sees 5 or 10 children with biliary atresia a year, new children, is considered a high-volume center in the United States. Most centers see a couple, and will never make progress waiting for those centers to perform a clinical trial or any other type of research. So NIH funded 15 sites in North America. We're in our 15th, now in our 16th year of funding. We've enrolled very large numbers of patients relative to these rare diseases. Over 1,800 children with biliary atresia have been enrolled, 400 with alpha-1 antitrypsin deficiency liver disease, and so on. And what we've developed are these longitudinal cohorts that are being followed through childhood, now many of them into young adulthood, collecting data in a specified manner using specific data definitions in a uniform manner across all sites, collecting specimens, storing them to create a biobank, including DNA, and with this, we're able to define natural history, endpoints that could be used in clinical trials, outcomes, identify biomarkers with the specimens that we have, and most importantly, conduct clinical trials in these large, well-characterized cohorts. So this is something that NIH has recognized, and most pediatric research groups are consortia, because again, pediatric diseases are generally rare. So these are the 9 diseases, and I'm really not going to speak to them. Many of these are many more than one disease. Some of them are 20 diseases, such as the mitochondrial hepatopathies, but these are the 9 categories now that our research network, called Childhood Liver Disease Research Network, focuses on. So let's just talk about some of the specific challenges and how we get around this. So the first is to find the right population to study. Every pediatric subpopulation is not equal. For instance, a newborn population may have completely different pharmacokinetic parameters and outcome measures that differ based on the post-conceptual age, the gestational age of the infant, the postnatal age, whether they had asphyxia at birth, whether they had a ductus arteriosus, et cetera, et cetera. This is not just newborns. It can be, for instance, teenagers. For instance, if you have 10 to 14-year-old girls that you're studying, some of them may be prepubertal, some of them may be undergoing pubertal, some may be postpubertal, some may actually have already had a pregnancy. And this dramatically affects liver metabolism, hormonal status, and response to a pharmacokinetic response to drug doses. So one has to keep all of that in mind. The right drug formulation, again, in treating adults, this is rarely considered unless you have geriatric populations that can't swallow pills. But in pediatrics, this is a big deal. Sometimes we have solid formulations, liquid, chewable, dissolvable, sprinkles that are added to foods, rectal administrations, transdermal. All of those are considerations depending on the type of study. And if you're giving a child something orally, it has to be palatable. You can't talk a baby into eating something that they're going to spit out at you. So there's a lot that has to do with flavors, with palatability, with texture, et cetera, that need to be taken into consideration. And then if we do use an adult dosage form, we need to verify that the child will swallow pills before they can be enrolled in the study. So sometimes we actually have to have that as part of their screening visit. You could bias enrollment in a study because you exclude younger children who might not be able to swallow a pill. And if some of this is culturally related or ethnically related, then you put immediate bias into the study that may not have been something that was included in the original study design. It's frequently difficult to titrate a dose in children, and this may not be sustainable. So there's some children that will take a medicine for a period of time, but then develop an aversion to that taste and then stop taking the medicine. So again, these are challenges that do come up in individual trials and unfortunately somewhat frequently. So we have various options for changing a dosage form. Sometimes we dissolve tablets in water or crush them in pudding, but water and pudding are not equal. So if one was in the middle of a trial and the child wouldn't take a tablet that was dissolved and we started putting it into pudding, we may completely change the absorption of that tablet. So I think we'll get beyond the type of preparations. I think you all understand that there's real challenges to doing this in a child. The other issue that's rarely considered in adults, it has to do with pharmacokinetic testing and blood volume. So children have a much smaller blood volume, obviously, than adult, and our IRBs have very strict rules about how much blood you can draw during a single blood draw, and then over a 2 to 4 week period. We base it on the child's blood volume. This usually is less blood than a typical pharmacokinetic study over 24, 72 hours would require. And because of that, we need to develop assays that can measure the drug and the metabolites on very small amounts of blood. Sometimes we stagger the blood draws, so some infants might get a 1, a 5, a 10, and a 20-hour specimen. Others might get a 2, 4, 6, 8-hour specimen, and you add those together to get a pharmacokinetic profile, but no individual child has all of those levels drawn. There's a certain degree of faith that all children will behave similarly when you do that, but sometimes you're forced to do that to actually be able to calculate volume of distribution, dosage, et cetera. And although it's been suggested in some studies, you can't do 20 finger pokes on a child to get a few drops of blood over a 24-hour period. It would seem that that would be scientifically valid, but not only ethically is it not valid, most families would withdraw from the study if that was the case. So again, these are challenges that we can overcome. We just need to think about these before we start a study. Many physiologic differences. I'm not going to go into all of these, but basically stomach emptying changes with age. Actually, bile salt export protein, one of the cholestatic genes that cause diseases when they're mutated, bile salt export protein expression changes over time, and if the drug is excreted into bile, this will have a dramatic effect. If you're giving a drug through skin absorption or rectally administered or intramuscular injections, again, there's differences in circulation, blood circulation, et cetera, that can affect the PK. Body composition, body water, body fat can affect it, the kidney elimination, and very importantly, the cytochrome P450 system within the liver undergoes a developmental maturation, which will have an effect on metabolism of different drugs. And then there's protein binding and the impact of feeding. Now, in terms of study design, there's also aspects that need to be taken into account before one sits down and even calculates out sample size, et cetera. And some of that is related to the amount of water that one would need to drink in order to consume a specific drug. It might actually overhydrate a child, which could be dangerous. If there's 24-hour urine collections, that may not be feasible in a small child. The number of visits for a study may exceed what a parent, a child, or the entire family unit can possibly do and maintain their family lifestyle or keep the child in school. Sometimes the need for 2 intravenous lines for administering an IV drug and drawing the blood sample out of the other line is not feasible in a small child, etc. Now let's just focus a bit on ethical issues. So risks and benefits, and although I didn't understand Mauricio's talk one bit, but I'm sure he talked to you a bit about risks and benefits. This is something that's very important in pediatrics, and there's a concept called minimal risk, and minimal risk is defined as the probability of harm or discomfort that is not greater than that ordinarily encountered in daily life or during routine medical testing, such as getting a physical examination. A typical physical examination is really minimal risk, and even obtaining a blood pressure or doing an ultrasound are minimal risk for children. Now there's the concept of minor increase over minimal risk, and that includes drawing blood, putting an NG tube down, CT scan, etc., where there's small risks, but there are true risks, and they're not risks that a child would normally encounter. And then there's greater than minor increase over minimal risk, and that's really now something like endoscopy or a liver biopsy, anesthesia, etc. And these are taken into consideration when an IRB reviews a pediatric trial, particularly for children that are in a control group, because rarely can children in a control group, can their parents approve of anything over a minor increase in minimal risk, and usually it's minimal risk for a control group. This is not the case in adult studies, where an adult can consent to almost anything as long as there's a full consenting process. And then benefit, obviously, has to show that there will be some progress in a new treatment, a diagnosis, prevention, better understanding of a disease for the group of children that are affected by the disease. But control children will never benefit from something like that if they don't have a disease. So this brings up what is allowable and what is not allowable for pediatric research. The European Union guidance states that minimal risk must have benefit for the individual or the benefit of the group for them to be in a study. A minor increase over minimal risk, again, has to show benefit, and the benefit-risk balance has to be in favor of that particular treatment. And then greater than minor increase over minimal risk has to be especially favorable in relationship to alternatives, or it's not justified for the child with the disease. So there's an alternative treatment that's very good for a disease, then a greater than minor increase over minimal risk really is not justifiable. In the United States, we're a little bit more liberal about that, and studies can be approved that don't offer a prospect of direct benefit to healthy children when they pose either minimal risk or a minor increase over minimal risk. So in the United States, we recognize that without controlled children, we'll be limited to the advances we can make. The EU guidance states, though, that the research on healthy children should not be performed, and the exceptions can include very simple things like palatability of a medication or a trial of vaccines. But other than that, in Europe, they really don't allow children that don't have a disease to really participate. So there's differences there. Informed consent is a voluntary agreement to participate in research. You've heard about that already. And we have to view the families and the children as partners in research and go through the informed consent process with the family as if they were participating. The parents or the legal representative is required to provide consent on behalf of the children. However, there's also a process called assent, and this means that we have an ethical and legal obligation to obtain a child's permission to participate in research if they're 7 years or older in the United States, and that's the age at which most believe that children can understand the concept that research isn't what you need, but it's voluntary. And if a child objects to being in the study, we cannot perform it on a child who's 7 or older. Now, frequently their parents have a conversation with them because a child who's affected by a disease and is in a research study may undergo some painful procedures like drawing blood, starting IVs, but if the child completely objects to it, we can't perform it. And then coercion is a concept that really comes into play in pediatrics. It's really important that consent's given without coercion. Payment for participating in research is generally allowed in the adult world. In pediatrics, our payments are generally only allowed if they reimburse the family for their own expenses, that we're not paying a family money to then allow their child to be in research. And this adds a lot of complexity in terms of inducements that one might think are being offered to the family. It's also found, though, and there's good research to show that when inducements have been offered, that it definitely can influence the parents' reasons for consenting, and there's a positive correlation between the importance of giving a family free medication for a reason as consenting. If the family can't afford medications and doesn't have good health insurance, or in the United States have large co-pays, but we will give them free medication to be in the study, that's an inducement, and some believe that's even coercion. Now, many of us believe it offers a family the possibility of getting a medication that otherwise couldn't afford it. So this is, again, a challenge, and different countries look at that differently. So my take-home points to you are that children are particularly not little adults when we're talking about clinical research. They may have different pharmacokinetics, the drug formulations may need to be different, there's physiologic differences and social differences and ethical differences in pediatric clinical trials. The risk-benefit ratio really has to be carefully assessed, but the bottom line is, without affected children and their families participating in clinical trials and in clinical research, we will never make progress, particularly in rare diseases. And what we've all seen is that rare disease foundations and patient advocacy groups really push us to be involved in research for those diseases, knowing that those children and their families will be left without treatments and hope unless research is performed. So I would just like to end there, and again, I thank you very much for inviting me here, and I look forward to the rest of the day.